Hello, and welcome to How Do You Keep Well, the podcast where we unlock the secret to amazing you, mind, body, and soul. I'm Dr. Jaye. I'm your host. I'm your cheerleader. I'm your guide as we navigate the fascinating world of women's health and well-being in this season of this podcast. Now, if you're ready to laugh, if you're ready to learn, and if you're ready to take charge of your health, you've come to the right place. And my mission here is simple. I want to empower you, yes, you, that incredible woman, and also men listening. I want to empower you to live your fullest, healthiest life. And I strongly believe that when women thrive, entire communities thrive. And that's my vision. My vision is to create a ripple effect of well-being where every episode of this podcast leaves you with something practical, something uplifting, and definitely something that makes you say, wow, I can do that. Thank you so much for coming back.
Hi, can you hear me?
Yes, let's go.
So I was saying that the cavity of the womb has to be checked. The lining of the womb has to be checked, usually by an endometrial biopsy. And if the patient has had 2 cesarean sections or more, then an ultrasound scan or MRI scan to check the thickness of the cesarean section scar should be done, because those are the things that may make the patient eligible or not to have an ablation. Also, if the patient's main problem is pain rather than bleeding, endometrial ablation may not be suitable, because that is only treating the lining of the womb to reduce or stop the bleeding or the heaviness of the bleeding. So if someone has chronic pelvic pain as their main symptom, even if they have heavy periods, the ablation alone would not be suitable treatment, because it won't necessarily address the pain. So also there needs to be counseling for the patient to understand the procedure, what it's aiming to achieve, what it can help, what it can't help.
That's interesting. We're going to talk about chronic pelvic pain, but I feel that there are still some treatment options for heavy menstrual bleeding that you would like to talk to us about.
Yes.
But I find that really
fascinating. Well, the thing is, there are quite a number of options, and it may be that people may need to try 1 or 2 or 3 to see what suits them. And hormonal treatments are suitable if the person is not trying to conceive, at least not at the moment, because many of the hormonal treatments are contraceptive in nature. So if someone says, I'm trying for a baby, well, the pill, the implant, the depot, the Mirena, they won't be suitable treatments because they will be contraceptive in nature.
Mm-hmm.
So this is the thing. Also, I warn people that the idea is to improve the periods with the hormones. But with hormones, you may also get unpredictable or unscheduled bleeding. So you may have people who have the depot, which you're supposed to get about every 12, 13 weeks. And when they get it, they have really heavy bleeding. Sometimes they say heavier than what they started out with. And that is not predictable. And so before people get the depot, I usually want them to say the downside of this is if you take the injection and you find out that you actually have this heavy bleeding, you can't remove the injection. You will have to wait it out because it's a 12 to 13 monthly injection. So that is something to consider. If you have the implant, it's generally to last up to 3 years. If you then have it and you find, oh, my periods are worse than they were, you will need to get the implant removed. That is an appointment in a specific kind of clinic. It's not necessarily as straightforward to just get any GP to remove it. So you need to bear that in mind. With the Mirena IUS, I highly recommend it because it can be contraceptive and it has non-contraceptive benefits in treating heavy periods. It is, for most people, going to stop periods or make them significantly lighter. Some people will not get on well with it because it can take up to 3 to 6 months to see the full benefit of the Mirena. So I tell people, I would request that you stick with it for at least 6 months because it's not immediate. Many people would see a noticeable, appreciable difference within about 3 months, but for some, it may be longer, up to 6. I would say if you think you want to remove it, I would say give it at least 6 months because most people would have a benefit by that point. If not, then yes, you can
Then take it
remove it.
out. I agree completely, and I'm a strong advocate for Mirena
For the
Coil
Mirena.
because I've
I have
seen it.
seen people though who have reported quite significant side effects, one of which
Mm,
can be a worsening of their mood. So
mm.
I didn't appreciate this as quite a significant side effect. It's not common, fortunately, but it does happen. So I have now started in people who already have quite significant mental health challenges to be a bit wary because for some people it can actually aggravate or worsen that side of their health.
I agree with you. And I say to some women, once progesterone, which is the hormone in Mirena Coil, once you smell it, your body reacts. Even just smelling it. So women are so sensitive to
Yeah.
progesterone, and I see that all the time. Even on or for some women in midlife going through menopause, using no matter what method you try, they are so sensitive.
Yeah.
But I want to move on very quickly and thank you everyone who is still listening to us, who have stuck with us. I really appreciate your time. But we're getting to the really juicy part, so don't go yet. This is one problem I find is very, very common, even though it's not often diagnosed for many women. In fact, they say that it takes about 7 to 8 years for some women to get diagnosed with endometriosis. And there is also the other bit, which is adenomyosis. But these are very common causes of pelvic pain. I would like tell us what is actually the difference between endometriosis and adenomyosis. I know both are common causes of chronic pelvic pain. Can you just talk us through what the difference is?
So endometriosis is when the tissue or the cells that make up the lining of the womb are, are found in areas outside the lining of the womb. So then you might find them on the ovary, you might find them on the tube, you might find them in the peritoneum, which is the layer of tissue that lines the pelvis, the abdomen. You might find endometriosis on the bowel, on the bladder. You might find them sometimes in cesarean section scars. You might find it in the lungs. So the lungs are not a common sight, but it has been reported where you find people coughing up blood in a monthly cycle with their period because the endometriotic tissue has found its way to their lungs somehow.
That is so
Fortunately, it's not a
intense.
common presentation. But adenomyosis is an area that is, being more talked about because it used to be said that it is a histological diagnosis. So the way to confirm it is if somebody has had a hysterectomy and then the uterus is examined in the lab and then they can see adenomyosis. Endometriosis, again, histological diagnosis is probably the gold standard, but the way to obtain histological diagnosis is through surgery. And every surgery needs to be done with caution because the surgery itself can pose risks. So, whilst the surgery may be done to try and diagnose something or treat something, the mere fact of the surgery itself has associated risks which need to be taken into consideration before undertaking surgical intervention.
Mm,
So,
mm,
there are ultrasound and MRI findings now being described to be able to diagnose adenomyosis. But
mm.
what I say to people is that in most instances in obs and gynae, your treatments are hormonal and non-hormonal. So
Yeah,
whether it's adenomyosis, whether it's endometriosis, whether it's heavy periods, whether it's painful periods, for pain, obviously analgesia is a
yeah,
treatment. But
yeah.
for the other parts of it, they are hormonal. So the adenomyosis is not like fibroids, where you would say there is an actual discrete fibroid that you may then be wanting to remove. Adenomyosis
Remove.
is more diffuse. It's how the actual muscle of the uterus has these changes.
On the
But what I say
inside.
to people also is that these things are not an exact science. So, what do I mean? There are people who say, I am performing a cesarean section and I see suggest possible endometriosis. So I said to the woman, oh, are your periods painful or anything? They're like, no, they're normal. No, I don't have any pain. So I say to people that a finding of endometriosis is not necessarily something that you need to be necessarily worried about. And also, not everybody who has heavy or painful periods or chronic pelvic pain will be diagnosed with endometriosis. They can be associated for sure, but they are not necessarily cause and effect. So I am very wary when people are like, oh, I just want to have a laparoscopy to confirm I have endometriosis, because I'm thinking, and it is the recommendation, if we do go in and see endometriosis, the treatment options are the same: pain relief, hormonal treatment. If the endometriosis has caused an endometriotic cyst, an ovarian cyst, that's a different matter, because then you might think that actually the cyst is big enough that you think that surgically removing it would be of benefit. But if the underlying problem is not hormonally treated, the cyst will reform, because those cells that are causing the bleeding and then the symptoms are still
Are
there and
still
are still
there.
being hormonally driven. So I think
Activated.
there's a lot of explanation that is needed, and then understanding that is needed for clinicians and patients to be able to understand what the signs and symptoms are. What are the treatment options for your own symptoms? What are we trying to achieve? What are the risks that could be associated? If we do nothing, what will happen? If we do hormones, what will happen? If we do surgery, what can happen? Because I think the more the discussion, understanding, rationale that people have, then the better their expectations can be managed and the better the outcome that can be achieved.
Is amazing. And you know what? Explaining it this way kind of gives me better insight, because sometimes as a GP, my patients come back to me saying, no, they didn't do this for me, or they didn't do that for me. But only God knows what happened in the consultation room. I think sometimes it's a bit of luck where you have brilliant gynecologists like yourself taking time to explain all the pros and cons and helping women to understand. And I think that's where the issue might be. Some may be that you will see good clinicians who explain things to you. Others may see clinicians who just want to do surgery for them and take their money. But also, the woman might be so overwhelmed by the symptoms that they are experiencing. And they've seen, oh, I've seen my friend Susan
She had
or
this,
whoever, she had this. Can I have it too? And she was better. So there's a lot about managing expectation. I have
there
one question
is.
for you.
Yeah.
I have one question for you, and it's about women going into perimenopause, menopause. You mentioned that some of the cysts or the endometrioma or the endometrioma hormonally driven. Now, when the hormones are depleting, are they going? Is it that the symptoms will get better then? Is it that
So,
Is it a myth that menopause cures endometriosis?
no, it's not a myth. No, it's not a myth. So, for instance, if people are experiencing pelvic pain due to endometriosis, we would expect that during pregnancy, for instance, that pain would be gone because you are no longer having cycles because you are pregnant. And most people with pain from endometriosis would say the same. Now, obviously, if there is a 10 centimeter endometriotic cyst and then the woman gets pregnant, that cyst is still there. So that cyst may still be associated with pain because there is an actual cyst. That is different from the pain from endometriosis without, for instance, a coexisting cyst as well, because not everybody who has endometriosis will have an endometriotic cyst or endometrioma, isn't it? So similarly, as one approaches the menopause and the cycles are less frequent, then the rationale is the same. that the pain that will be cyclical with periods will be less because the periods are less. But if the periods are not less, then the pain will not necessarily be less, because the reason one is getting the pain from endometriosis is because those cells that are now outside the womb will bleed and cause the irritation in the pelvis or wherever they are to then cause the pain. So I think we need to be working out what we mean by menopause cures endometriosis. If somebody has had quite significant endometriosis, where there's been a lot of adhesions, everything is stuck. The bowel is stuck to this and that is stuck to that. Those adhesions are not going to go away because you have now stopped having periods. The adhesions will remain. So the pain from that possibly will persist because the things are stuck together. They can't move freely as they would have if there was no adhesion. So it's again trying to understand what is the mechanism of this pain. Many people will have coexisting either inflammatory bowel disease or irritable bowel disease. That is a contributor to pelvic pain. Some people will have bladder pain syndrome, which again, interstitial cystitis, will contribute to pelvic pain. Generally, during the period, during ovulation, the pelvis has more blood supply, is more congested, is more uncomfortable, is crampy. That is expected and cyclical, not necessarily endometriosis at all. So I think there's more education needed to be able to say to people that there are so many things that could be causing the pain. It's different if you have a cut. You can literally see there's a cut. It's bleeding, it's painful. That is clear. But not everything is as clear cut as that.
That is so, it's almost like lights for you just explaining that not everything is necessarily endometriosis. There are so many different contributing factors. And like you said, the pelvic area is such a small, not, I mean, small but big area that
There are
so
many organs
many
in there.
organs squeezed in that area that can be causing so much issues. And I quite like your explanation of pelvic congestion. And that some women, I have had women who have been investigated so many times, had so many treatments, still coming back with pain. And it might just be that we need to manage those kind of expectations. Now, one last area before we finish is you talked about bladder. And I just want to touch base a little bit on bladder issues, perhaps slightly outside of heavy menstrual bleeding that we've been talking about or endometriosis. I find as a GP, GP with special interest in women's health, when I examine women, at least half of the women I examine in that age group in midlife have evidence of pelvic organ prolapse, whether or not it's the vaginal wall or whether or not somewhere inside there looks weak. But not many of them complain of these symptoms at all. They're actually fine. But the few that complain have it really badly. Can you talk about why bladder issues are actually common in midlife? Why, when do they start noticing these changes in their bladder and in their pelvic floor? What to do and maybe what to look out for? Because many women don't even know what to look out for as well.
So with prolapse, I tell patients that a prolapse only needs treatment or management with respect to the symptoms the patient has. As you say, you will have an incidental finding of some form of prolapse in at least half of women. Prolapse is contributed to again by several factors, whether vaginal prolapse or uterine prolapse or uterovaginal prolapse. Front wall of the vagina related to the bladder, back wall of the vagina related to the bowel, the top of the vagina if the patient has already had a hysterectomy, so vault prolapse, or uterine prolapse if the womb is coming down. The contributory factors include obesity, chronic cough, chronic constipation, pregnancy. Then the method of delivery. So for people who feel that, oh, I'm going to have a cesarean because I want to reduce the risk of prolapse, you might reduce the risk of prolapse from the point of view of an assisted vaginal delivery, a difficult vaginal delivery, a vaginal delivery at all. But the weight of the pregnancy has its impact on the pelvic floor muscles. So pregnancy in itself is a contributory factor. Then you have musculoskeletal contributors. If somebody has Ehlers-Danlos syndrome, then, there are connective tissue. So there are so many things that contribute. Right. Now, if someone has no symptoms of their prolapse, then I can submit to you that prolapse does not need treatment because
That's great.
It's there. It doesn't need treatment. It's not bothering them. It's like saying that you have a mole, a skin tag. It's there, it's there. It's not doing anything. It doesn't change color, become larger, start bleeding. Then you think, oh, we need to get that sorted. So a prolapse is a benign condition. It does not need treatment just because it exists. There are also people who say, oh, I have a prolapse. It's causing me to wee frequently. And I say that may not necessarily be the case. You might have urinary frequency, urgency, incontinence without a prolapse. A prolapse does not cause these things. They may be associated and coexist, but a prolapse will not cause it. Now, if the person has quite significant prolapse where the whole womb has come out, then yes, that can have an effect to cause urinary retention because the whole anatomy and positioning is distorted. So then emptying the bladder or the bowels can be difficult because actually the whole uterus, the vagina is inverted. That's different. But just for a rectocele from the back wall, a cystocele from the front wall, those are not expected to be causing urinary retention.
Significant symptoms.
Yes. So we kind of have to look at them to say, because you will then find people sometimes, and this is what urogynecologists will tell patients, if you have quite significant uterovaginal prolapse, you are operated on, it may actually now reveal more urinary symptoms than before your operation, which the operation didn't cause. It's just that actually this is now more of an issue because the prolapse has been dealt with. So the first thing is not all prolapse need treatment. The second thing is when prolapse does need treatment. So some people say, I have a dragging sensation. For some people, the whole uterus is actually out vaginally. That is quite significant. There is surgical and non-surgical treatment. Again, if the patient is wanting surgical treatment, I usually say to them, if you have a uterine prolapse, and it is surgically treated, the womb is removed, vaginal hysterectomy. You can no longer have a uterine prolapse because the uterus has been removed. However, you can still have a recurrence of a vaginal prolapse. So be aware. And then many of them are like, oh, I didn't know that. So I say, yes. The recurrence rate is at least 30%. So 1 in 3 women who have had vaginal prolapse surgery will have a recurrence. Therefore, consider carefully whether you want to have surgery because the chance of recurrence is there. Also, the younger you are, the more likely you will live long enough to have a recurrence because you are living long enough, right? So if you have prolapse surgery at 40, average expectancy 80, you have 40 more years for your prolapse to recover.
Of a risk.
Surgical operations are less likely to be as effective as the first one. So it's not just a case of, well, I'll have another operation and I'll have another operation and I'll have another. It's not quite that straightforward. And the outcome may not necessarily be as expected. Again, to bear that in mind. So usually it's trying to balance pros and cons. What is prolapsing? What is the effect it's having? Are you willing to undertake the surgery, bearing in mind it may not be a final cure? Obviously, surgeries have their risks, bleeding, infection, blood clots, being out of your normal action for some weeks. All that, again, is obviously to be considered. So prolapse is a benign condition generally. The management, I would say, should be in line with the patient's symptoms. With regards to the urogenital changes of perimenopause. For most people, vaginal estrogen will be sufficient, either as a cream or as a pessary. Oral, transdermal, spray, gel HRT is not needed and is not usually effective for urogenital symptoms of the perimenopause. So
That's
I would say
interesting.
most people would benefit from vaginal estrogen, and the absorption and the amount of estrogen delivered is very small compared
Very
to
small.
oral, transdermal, other parenteral routes, and also the associated risks of HRT, DVTs, PEs, all those sorts of things are not associated with
It's
vaginal
reduced.
preparations. In fact, hardly existent, if at all existent. So, vaginal estrogen can be given liberally forever for perimenopausal urogenital symptoms.
Syndrome.
Obviously,
Amazing.
if there is any history of breast cancer with estrogen receptor positive and progesterone receptor positive, then that's a different matter entirely. But for most women, that would not be their situation. So vaginal estrogen can be given in the perimenopause, through the menopause, in postmenopause for urogenital symptoms that are associated.
Symptoms. Amazing stuff. I find that with my women, because I work in a women's health hub and we do a lot of prolapse. We fit in a lot of pessaries and all sorts of different things for women. I think that can be useful as well as a hold, especially where you talked about the recurrence. So in any case, any woman having some of these symptoms and they are not too sure, the best thing is present yourself, ask for help. Don't be scared. Like Dr. Maureen talked about earlier on, Mrs. Muoka, she talked about being a woman consultant. She felt like she would be able to meet the needs of certain women who feel that they need to see female doctors. And there you are. There are people available there to help you. So make sure you ask for help. Now, often, we're concluding now, many women feel dismissed when they bring up these concerns. What advice do you have for women to advocate for better care for themselves?
So I think that, as we mentioned earlier, taking responsibility for your own care is important. I say to people, and I'm surprised that it's not public knowledge, but I say to people, there are Royal College of Obstetricians and Gynecologists patient information leaflets about so many conditions available on the internet. Go and read a certified source of reliable information so that when you are going to the GP, you have some idea of what your symptoms are, what it could be, what you are concerned about, and you can articulate it. I heard something yesterday when I was attending the Black Maternal Health Conference virtually. It was organized by the Motherhood Group. And they said, go with someone to your appointment, because sometimes you may feel overwhelmed, you may not remember, you may have forgotten what you wanted to say. Go with a trusted person, because they may say, oh, but you mentioned you wanted to ask about this. Oh, yes. Or when you leave, the doctor said that. Oh, yes, they did say that. So go with someone. Do your own research from reliable sources. The NHS website, the RCOG. Nice. Some of their guidance, I think, is also available to the general public so that you are already educated to some degree. I'm not saying random Google searches and TikTok from things that you may not be able to certify. I'm saying reliable sources. Because then you are
I think that's really important.
Yeah, you are armed and
with the correct information.
With some authority to say. There was something else that they said at the conference. They said, ask the clinician, can you please document that I raised this as a concern and this is what you've said about it? Also, ask for a second opinion, because your second opinion may be what this first person has said, or it may not be. There's no need to be rude, but I think it's all right to ask for a second opinion.
Wow. And that is where I would like us to end that today. It's incredible the amount of information you have shared today. And I feel that for every woman who is listening right now, or any man who is listening, you can help women around you. One, to recognize, to raise their awareness, but also to advocate for them. Go with people to their appointment. Signpost people to the right, reliable sources of information. And that is one reason I will keep doing this podcast as long as I can, because I feel there's need to get the right information out to the people who need it most. And we need people to signpost us to this right information. Sometimes the 10-minute appointments with your GP cannot do justice to some of what we've discussed here today. So hopefully you can get the information from reliable sources and not just going on TikTok to get a description. Oh, that's me. That's exactly what happens to me. And that's exactly what I'm going to tell my doctor. You may find that no one size fits all. And that's why you need the help of reliable healthcare professionals to guide you through. I really hope you found this helpful, everyone. Thank you so much, Dr. Maureen. Thank you for spending your Saturday morning with us. I really appreciate you. And thank you for sharing your information very generously as well. So if there's one takeaway that you would like us to take away, thank you so much. One takeaway from today, what would that be to any woman or maybe any man listening to this to help their woman?
I would say take responsibility for your own health and get your information from reliable sources. Because or at least you have an idea of what your symptoms are, what you think they could be, with the right source of information, you are standing yourself in a better stead to present yourself in a way that hopefully will be able to get you further forward. Also have realistic expectations. If you've had a problem for several months or years, it's not going to be cured instantly. And actually, sometimes it may not be cured. It may just be that it can be improved. So those would be my 2 takeaway points.
Takeaway. Thank you so much. Thank you. I really appreciate from my heart. I want to say thank you. And for everyone who has joined us, who is listening, who is cheering me on, you know yourselves, and who is going to share this episode, you know yourself. Please share it with a friend. And don't forget to subscribe and follow us for more conversation on women's health in the next couple of weeks and months. So thank you very much. Bye.
Thank you. Thank you.